Before we start, you need to recall the two terms, that is transport maximum and renal threshold for glucose. Now, what is transport maximum? For many reabsorbed substances, the rate of reabsorption has a maximum upper limit. That is, no further reabsorption is possible once that maximum limit is reached. Now, for glucose in kidney, the transport maximum is written as TmG, and the maximum transport that can be I would say rate that can be achieved is 375 milligram per minute. So this is the transport maximum for glucose in kidney. Next is, what is renal threshold? Now, renal threshold, it is the plasma glucose concentration. This is the plasma glucose concentration. Crossing above this concentration level, glucose first appears in urine. That is, for plasma glucose in kidney, the theoretical value, that is PTH for theoretical glucose, is 300 milligram per deciliter. You get it? This is renal threshold is the concentration and the transport maximum is a rate. One important thing is that contributing transport maximum, the total number of the nephrons, that is, one kidney has got 1.3 million nephrons, another kidney has got 1.3 million nephrons. Now, together these 1.3 and 1.3, that is total 2.6 million nephrons contributes to the transport maximum. All the nephrons in both kidneys are not equal in function, so we can call it a overall transport maximum. It is overall transport maximum. Now let's draw the glucose titration curve. In x-axis, plasma glucose concentration is drawn and the value is in milligram per deciliter, and in y-axis, the glucose which is filtered or reabsorbed or excreted, and the rate of this glucose filtered, reabsorbed or excreted is drawn, and it is the value is given in milligram per minute. Now, as you know that transport maximum of glucose is 375 milligram per minute, let's draw a horizontal line on that. So this is the TmG or transport maximum for glucose. First we draw glucose filtered load rate versus the plasma glucose concentration. As GFR is kept fairly constant, that is 125 ml per minute, we get a straight line for the filtered load. That is, as much glucose is delivered to the glomeruli, that much is filtered, so we get this straight line. We get this green line for the filtered. Next we will plot the reabsorbed rate versus the plasma glucose concentration. Now, at low plasma glucose level, all the filtered load of the glucose is reabsorbed, so we get again a straight line, and as the plasma glucose concentration increases, the reabsorption also increases, and simultaneously it will go and we get this straight line. Now, at higher plasma glucose level, now suppose it has reached around 300 milligram per deciliter. Now the transport system gets saturated once it reaches to the 375 mark, that is the transport maximum of glucose. So beyond that level, no further glucose reabsorption is occurring. The curve will be now horizontal to the x-axis, as there is no more reabsorption of glucose, as it has reached the transport maximum of glucose. Whatever may be the plasma glucose concentration, like 400, 500, no more glucose can be reabsorbed. So we have got this blue line as reabsorbed plot, reabsorbed plot. The third curve is glucose excreted or excretion rate versus the plasma glucose concentration. Now, at low plasma glucose concentration, all the filtered load is reabsorbed, so glucose is virtually absent in urine. As glucose concentration increases and reaches a very high level, and it exceeds that threshold level, that is the 300 milligram per deciliter, that is theoretical value. That's why TH is written PTHG, that is the renal threshold for glucose. Renal threshold. The transport system is now fully saturated or occupied, and the load is beyond the transport maximum, so glucose starts appearing in the urine. The curve obtained is a straight line. So this red line we have got is for excretion. Up to this, what you have seen is called ideal curve. Ideal curve. But this is not the case. What happens? In practice, actual titration curve is rounded and deviates considerably from the ideal curve. The deviation is called splay. The actual titration curve for reabsorption goes like this and continue like this. The actual excretion curve deviates from the ideal curve and goes like this. Now this deviation and this deviation, these are called splay, means deviation. For excretion curve, this 200 milligram per deciliter plasma glucose concentration is called the actual renal threshold for glucose, and the plot goes like this. Let continue. It's a straight line. Now, what is the cause of this deviation, that it deviates from the ideal curve? What's the reason behind it? One of the cause is nephron heterogeneity. Nephron, that is, all the 2.6 million nephrons are not exactly same in activity. There is a variability of filtration capacity of the glomeruli is also different, and reabsorptive capacity of the renal tubule is also different. So some nephrons have lower reabsorptive capacity. Suppose this nephron has got lower reabsorptive capacity, or we can say low TMG for this nephron, and as there is low TMG, it will excrete plasma glucose much lower than the normal, and suppose this one has got higher reabsorptive capacity or higher TMG, it will excrete the glucose at higher plasma glucose than the average nephron. The distribution density of the glucose transporter can be also different. This is the distribution of the glucose transporter, that is SGLT, sodium dependent glucose transporter, SGLT1 and SGLT2. This is one nephron, and the density of this nephron may be higher, so the reabsorptive capacity of these two nephron will be different, and the size of the glomeruli may also be different. This one is smaller, this one is larger, so it can handle more amount of filtrate or glucose. Another point is glucose transport is carrier mediated. Affinity of the transport system for glucose is very high. It is affinity, but the binding of carrier with glucose is not completely irreversible. We can write that glucose plus receptor, that reaction, there is glucose receptor complex, and the reaction is somewhat extent reversible. So some amount of glucose will appear in urine although reabsorption rate is below transport maximum for glucose, and this reaction follows saturation kinetics that does not allow all the glucose to bind with all the carrier proteins at a time. That is, at a point of time all the glucose cannot bind with all the receptors present. We can say that all the receptor carrier proteins are not active at a time. Slightly more concentration of glucose must remain in the tubular fluid to saturate the transport system. So some glucose will appear in urine before the saturation. In other words, all the carriers can be utilized only when the number of glucose molecule is more than the number of carrier proteins present. So extra glucose comes out in urine at a value lower than the ideal transport maximum of glucose or ideal plasma glucose threshold level. If you have any question, please feel free to ask me in the comment section below. I will try to answer that questions. I have provided some questions in Google form. Link is given in the description below. You can check that questions.